Hello everyone, I hope everybody's doing well. Today I'm going to talk about CPAP and BiPAP. I'm just going to give a brief explanation of CPAP and BiPAP. CPAP and BiPAP. So I'm just going to talk about what are they and how they work. Just a brief explanation. So CPAP, right? CPAP stands for continuous positive airway pressure. What a CPAP is just a continuous pressure that pushes to the upper airway and eventually to the lungs to keep the airway open. CPAP is a pressure above atmospheric pressure. So there's a pressure that is compressing at us right now, which is atmospheric, and it depends on your location as well. So atmospheric pressure is about 760 millimeters of mercury, and when you convert it, it goes, I think, to 0 centimeters of H2O, of water, right? CPAP is not measured in mercury. It is mostly a pressure that is measured in centimeters of water. So every CPAP pressure that I've seen in my respiratory career, it starts at 4 centimeters of water. So that means it is 4 centimeters of water above atmospheric pressure. CPAP is kind of like, when you're driving and you stick your head outside the window and you feel a pressure of air that is pushing. It's a similar pressure that is going through the CPAP. And it's continuous, okay? So what happens is when you go, most likely CPAP, most of the time it's used for OSA, obstructive sleep apnea. So an obstructive sleep apnea is when people go to sleep, there's a muscle behind the tongue or the tissue on the pharynx. There's a crowd of tissue there that obstruct the flow of air that goes into the lung. So when there's no air going to your lungs, that means no oxygen, your brain sends a signal to wake up, and you keep waking up. So sleep apnea, it's almost like, I don't want to get into sleep apnea, but I just explain it just for the fact of CPAP. So sleep apnea is similar, such as like if somebody is sleeping next to you at nighttime and every 5 minutes they just shake you up and wake you every 5 minutes. Can you imagine the whole night you're sleeping with someone who's waking you up every 5 minutes? The next day you're gonna have a terrible day because you didn't have enough sleep. So sleep apnea is a similar way. What a CPAP does is it keeps the airway open. So when it keeps the airway open, that means there's airflow going in and out of your lung. So if there's no obstruction of flow, there's no stopping of that air that goes to your lungs. So you sleep very well at night. That's what most of the time they use CPAP for OSA. But it is used for other things as well. So it is just one continuous pressure, one pressure that is continuous, okay? And the other hand is BiPAP. BiPAP is 2 pressures. So in BiPAP, you have 2 pressures. You have an EPAP and you have IPAP. So inspiratory positive airway pressure and expiratory positive airway pressure. So you set 2 pressures, and those pressures, that's when it drops. It goes up to the IPAP pressure that is set, and it drops to the EPAP pressure that is set. Most of the time, the BiPAPs, however, BiPAP sometimes is used for, so since we talked about obstructive apnea, sometimes we use a BiPAP for central sleep apnea, which is okay, I just made it. Okay, this is an CSA, central sleep apnea. it is used for central sleep apnea. I'm not gonna get into detail with that, but it is very successful to use a BiPAP for central sleep apnea. However, in hospitals, it is used most commonly for COPD patients, and I'm gonna focus on that as well. So, in the hospital, they will do an ABG for a patient, COPD or not COPD. Or sometimes it is used for CHF patients, congestive heart failure as well, to just relieve the patient from respiratory distress. So after the ABG is done, you might get an ABG like, I'll give you an example, 7.2, and the CO2 is, let's say, 60 or 68. The CO2 is 68, okay, and the PO2, let's say it's 85, the PO2, okay. So BiPAP will be ordered. Now, how is that gonna manage to bring the ABG results as a normal ABG? In COPD patients, sometimes you won't be able to bring it to normal because they're already retainers, but it is temporary, so you want to use BiPAP to wash out the CO2. So we want to wash out the CO2, okay? So have in mind that, let's say you start with the IPAP and IPAP. Let's say you start with an IPAP of 10 and EPAP of 5, okay? Those two pressures. So the difference between IPAP and EPAP, what's recommended textbook-wise, they say 4 to 7 millimeters of mercury. So 4 to 7 millimeters or centimeters of water. Sorry, centimeters of water, because I'm not going to use that. Centimeters of water. Have that in mind. It is not mercury. It is centimeters of water. This is book-wise. That's the difference they want between IPAP and EPAP. Okay. So the higher the difference between them, the more tidal volume you will have. And the more tidal volume, the more CO2 you will wash out. Example, if I give you 5/10 to wash out the 68 and still there's no results, you can increase IPAP. So let's say the 10/5 is giving you a tidal volume of 400. If you increase the difference between them, which is, let's say you give it to let's say 14/5, the tidal volume will be 550 at least. This is just an approximate, which therefore this tidal volume, because you're putting more volume to your lung and taking it out, so the more volume, the more CO2 will be washed out. So the more volume, the higher the CO2 will be washed out, okay? In this case, now we understand this is how we're gonna wash out the CO2. When you talk about IPAP, when you talk about IPAP and EPAP, this is what I want you to have in mind. Always think of ventilation. In EPAP, always think of oxygenation. Okay? When you want to ventilate the patient, you want to wash out the CO2, so you're going to increase only the IPAP. Like I said here, it was 10/5, and we increased it. We went up increased it to 14/5. It gives us some more tidal volume, and it washed out the CO2. However, this is IPAP, correct? And also vice versa. Let's say if there was CO2 was being washed out a lot, you can lower the IPAP. Okay, you can lower. Okay. EPAP and positive end expiratory pressure it is the same as PEEP, similar as PEEP. Okay, so when we increase PEEP in the vent in patients, what the main goal is to improve what? Improve oxygenation, correct? Therefore, if let's say that this, let's go back to this blood gas that I gave an example. Let's say the PO2 was lower. Let's say the PO2 was 40. It is beneficial if you increase IPAP as well. So if you want to wash out the CO2 and also improve the oxygenation, instead of just increase it to 14, you only increase the IPAP, you can increase also EPAP because you want oxygenation as well. So it's going to depend on the blood gas that you get. And this information, as a respiratory therapist, you should know this, because a doctor won't know this. A doctor will only give you an order for BiPAP. Not all doctors, but some doctors might not know this, especially doctors who are just starting in their career, such as the residents and everywhere in the hospital. Okay, so you should know this as a therapist. So EPAP, increasing it will help you with oxygenation, and IPAP will help you with ventilation. And always remember, when you increase IPAP, you have to increase EPAP only if you want to improve oxygenation, okay? But if you want to improve only the ventilation to wash out the CO2, just increase the IPAP. However, but if you want to improve both, you have to increase both. But if you have to increase only EPAP for oxygenation, you should also increase IPAP. Because if you only increase, let's say 5/10, and you want to get better oxygenation, you want to increase the IPAP to 7, you shouldn't leave EPAP at 10, because right here you are lowering the tidal volume that the patient is getting. So you might as well, if you increase this is 2, you want to increase this 2, so we will go 12/7. Okay, so this is only way you will go together if you want to improve. Okay, and hopefully this helped you in any kind of way. And CPAP, okay, another point that I should give out: if these two pressures are the same, if IPAP and EPAP are the same pressures, which is 10/10, this is a CPAP mode now. It is not a BiPAP anymore. Not BiPAP, because it's only one continuous pressure now. You don't have two different pressures. All it is you're given CPAP. That's what you're doing. If you make BiPAP 10/10, if you make it the same pressure, so if you make IPAP and EPAP the same pressure, you are delivering CPAP to the patient. Have that in mind as well. Thank you so much. I hope you enjoyed this video, and stay tuned for more videos. I'll be uploading more videos to help people out there, future respiratory therapists or respiratory therapists in mind, or anybody who wants to learn. Thank you for listening. If I made a mistake, like I always say, please forgive me, and comment below, point out my mistake, or if any corrections you want to make to my video, feel free to give me any advice. And please like, share, subscribe, and do all the other stuff. Thank you so much.